This is Anesthesia Circuit with John Kenny, a resource for the busy anesthesia provider and the only show dedicated to all things anesthesia. Listen in your car, at the gym, while you set up your room in the morning, as you cram for a test, or in your free time. Sleep, why it's important and how we can improve it. Opioids and renal failure. Placental changes in pregnancy. Perioperative nutrition and how to improve it. The rates of heart attack are on the rise in pregnant women, and important conference dates. This and more on today's episode of Anesthesia Circuit with John Kenny, the only show dedicated to all things anesthesia. Have you ever thought to yourself, hey, I'm just going to put a few more minutes into this work, a few more hours into this project, and I'll feel so much better tomorrow morning that I've done more work on it? And you're basically sacrificing sleep for work. Well, you may be doing much more harm than good according to the most recent research on sleep hygiene. So that's why in today's personal health segment, I'm focusing on sleep. So what are the benefits of sleep, and then what we can do to improve them? All right, so let's start right in with the benefits. So what we know is sleep improves memory. Sleep consolidates, stores, and strengthens skills and memories while we sleep through a mechanism called neuroplasticity. We know that people who tend to get more sleep live longer. Also, sleep decreases inflammation. People who have less than 6 hours of sleep nightly have higher levels of serum CRP or C-reactive protein because inflammation is linked to heart disease, stroke, diabetes, arthritis, and premature aging. You're all at risk for these if you don't get enough sleep or if you have those higher levels of inflammation. Now, sleep increases creativity. Researchers at Harvard and Boston College found that people seem to strengthen the emotional components of memory during sleep, which may help spur the creative processes. So, also improves stamina and athleticism. This interesting study from Stanford University found that college football players who tried to sleep at least 10 hours a night for 7 or 8 weeks, I know, 10 hours, really? Anyway, it improved their average sprint time, and they had less daytime fatigue and more stamina throughout the day as well. We know that sleep improves grades, improves attention to tasks, also is associated with weight loss. Now, researchers at the University of Chicago found that dieters who were well rested lost more fat of their weight loss than those who were sleep deprived, who lost more muscle mass. Now, they lost about the same amount of weight, but most people are looking to lean up and not kind of soften out, I guess, when they're dieting. Sleep and metabolism are controlled by the same sectors of the brain, Dr. Rappaport says, who's one of the main authors on this study. When you're sleepy, certain hormones go up in your blood, and those hormones are the same that drive your appetite. All right? Now, also we know that sleep lowers stress and cholesterol, it decreases your risk for accidents, and it improves your emotional stability. A lack of sleep can contribute to depression. A good night's sleep can really help a moody person decrease their anxiety. You get more emotional stability with good sleep. All right, so now what can we do? How can we improve our sleep hygiene? Well, the National Sleep Foundation is an excellent resource for this. They actually give great guidelines on the basic steps that we can do to improve our sleep. So I highly recommend you check out the website for the National Sleep Foundation. All right, so what do they say? What are the recommendations? Well, they say one of the most important sleep hygiene practices is to spend an appropriate amount of time asleep in bed, not too little, not too excessive. Sleep needs vary across ages and are especially impacted by lifestyle and health. So most of the people who are listening to this are probably going to fall in the 7 to 9 hour sleep range. Everyone's a little bit different, but that's typically between 18 and 65 years old. Now, however, there are recommendations that can provide guidance on how much sleep you need generally. Other good sleep hygiene practices include limiting daytime naps to 30 minutes or less. A short nap of 20 to 30 minutes can help to improve mood, alertness, and performance. So that may be something that you want to include in your day if you can. Now, avoid stimulants such as caffeine and nicotine close to bedtime. Now, that tends to go without saying, but even people who say, oh, I can fall asleep, right after drinking, a cup of coffee or something like that, it may actually be disrupting your sleep. Also, nicotine. Yes, nicotine is a stimulant, and that may disrupt your sleep as well. Okay. Now, when it comes to alcohol, moderation is key. Alcohol is well known to help you fall asleep, but too much close to bedtime can disrupt sleep, especially in the second half of the night when the body begins to process the alcohol. Exercising promotes good quality sleep as well. Now, listen to this. As little as 10 minutes of aerobic exercise, such as walking or cycling, can drastically improve nighttime sleep quality. 10 minutes. I mean, I don't know anybody who doesn't have 10 minutes. All right, for the best night's sleep, most people should avoid strenuous workouts close to bedtime. However, the effect of intense nighttime exercise on sleep differs from person to person, so find out what works best for you. Steering clear of food that can be disruptive right before sleep. Okay, so heavy, rich foods, fatty foods, fried meals, spicy dishes, citrus fruits, carbonated drinks. These can all trigger indigestion for some people, and when it comes close to bedtime, that may actually disrupt your sleep if you're in bed uncomfortable. Okay. Now, ensure adequate exposure to natural light. Now, this has to do with your sleep-wake cycle. This is particularly important for individuals who may not venture outside frequently. Exposure to sunlight during the day as well as darkness at night helps to maintain that healthy sleep-wake cycle, or that circadian rhythm. Establishing a regular, relaxing bedtime routine also is a great thing to do. A regular nightly routine helps the body recognize that it is bedtime. It gives you these cues, these subconscious cues that, hey, we're prepping for bed, guys. Let's go to sleep. This could include taking a warm shower or bath, reading a book, light stretches, something like that. When possible, try to avoid emotionally upsetting conversations and activities right before attempting to go to sleep. Now, making sure that the sleep environment is pleasant as well. Mattresses and pillows should be comfortable. All right. Go out, buy a new mattress if it's uncomfortable. If you've had it for 15 years, I think that the recommendation is 8 years or so that you should always change your mattress. Invest in that. You spend a third of your life in bed. Get a new pillow. Get a pillow that works. Sleep technology has improved so much over the years that there's something out there that will help you. Now, the bedroom should be cool. Now, this is pretty cool to me, but between 60 and 67 degrees, the National Sleep Foundation recommends. That seems a lot cooler than I usually have my house, but hey, that's for optimal sleep. Now, bright light from lamps, cell phones, and TV screens can make it difficult to fall asleep. So turn those lights off, adjust them when possible. Consider blackout curtains, eye shades, earplugs, white noise machines, humidifiers, fans, or other devices that can make the room more relaxing. For more information, check out the National Sleep Foundation's website. So our keywords today are opioids and renal failure and placental changes in pregnancy. So let's get right into it. So opioids and renal failure. So analgesia in patients with renal disease who require opioids have obvious risks in prescribing their use, and this population should be, the prescription should be performed with caution. This list that I'm going to go through here goes through medications or opioids that typically are avoided, ones that are often used with caution, or ones that are just typically used because the risk of that decreased elimination from renal failure, that risk really doesn't pose any increased risk to the patient. So typically avoided. So codeine. Codeine is metabolized in the liver to codeine 6-glucuronide, norcodeine, morphine 3-glucuronide, and morphine 6-glucuronide, and then morphine as well. And so morphine and morphine 6-glucuronide are considered the active metabolites. Inadequate excretion can lead to the potential respiratory depression, hypotension, and narcolepsy. So for morphine, we just talked about that. Morphine, or a little bit. Morphine's metabolized to normorphine, morphine 3-glucuronide, morphine 6-glucuronide, all by the liver. These three are ultimately excreted by the kidneys. Morphine 6-glucuronide can accumulate and cause respiratory depression, hypotension, and narcolepsy. For hydrocodone, it's a parent drug, and its active metabolite can accumulate in renal failure. It's metabolized to hydromorphone, and this can eventually lead to hydromorphone 3-glucuronide, which can then lead possibly to neuroexcitatory effects like agitation, confusion, or hallucinations. And then meperidine. its active metabolite norepinephrine can accumulate in renal disease and cause seizures or decrease the seizure threshold. So that's actually often a tested question. Okay, which of these medications in renal failure is associated with seizures, and or meperidine is it? Or what is the metabolite that is associated with seizures when given meperidine, and that's normeperidine. Now, the medications that are used with caution is oxycodone. It's metabolized by the liver with metabolites being excreted by the kidneys. 10% of the parent drug is excreted unchanged by the kidneys. And oxymorphone is the active metabolite. However, plasma levels are usually pretty negligible. For hydromorphone, now this is another one that's used with caution. It's metabolized by the liver and produces active metabolites, is hydromorphone 3 glucuronide. This metabolite can accumulate and cause neuroexcitatory effects, and it's currently thought to have no analgesic properties. Now we're moving on to the typically used medications. Now these medications are ones that are fine in renal failure, in your dialysis patients or your patients who are on the cusp. So fentanyl, sufentanil, alfentanil, they're all metabolized by the liver without any active metabolites. So they're safe, they're fine in renal disease. Methadone. Now this is great. This is one that is used all the time in renal failure patients for the longer acting pain medicines. It's fecal and urine renally excreted without any active metabolites. And so it's considered safe across the board typically. And then Remy Fentanyl. Now, as we know, Remy Fentanyl is metabolized by non-specific plasma esterases into active metabolites, actually into inactive metabolites, which makes them safe to use in those renal failure patients. So, onto the advanced keyword, placental changes in pregnancy, or placental changes in preeclampsia, I should say. So, I'm going to start with preeclampsia and then kind of go through those changes. Preeclampsia is the presence of hypertension, so it's sustained hypertension, systolic blood pressure greater than 140, diastolic blood pressure greater than 90 while sitting, and some evidence of new onset end organ dysfunction. And these are both after 20 weeks of gestation as well. Okay. So the pathogenesis or the placental changes. So normal trophoblastic cell invasion into the spiral arteries, which occurs in the first 18 weeks of pregnancy, is incomplete or may not occur. Decidual arteries are constricted with high resistance. So this is one of those changes. Now, because of this, oxidative stress via increased subendothelial LDL accumulates, which recruits monocytes that cause increased lipid peroxidation. Now, free radical and lipid peroxidases cause membrane damage and subsequent edema, proteinuria, causes inhibition of nitrous oxide production, increased endothelin 1, increased thromboxane, and decreases prostacyclin. Now, what we know, so acute arthrosis via decreased prostacyclin, increased thromboxane, endothelin 1 upsets the usual balance between the substances that lead to thrombosis and vasoconstriction of vessels in the placenta and systemically. Now, we know that prostacyclin decreases vasoconstriction and platelet aggregation, uterine activity, increases ureteroplacental blood flow. And what we know is in the case of preeclampsia, there's decreased prostacyclin. We also know that nitrous oxide is a potent vasodilator and it's an anti-aggregatory. And we actually have lower nitrous oxide production in preeclampsia as well. Now, thromboxane, we know that that typically increases vasoconstriction, platelet aggregation, uterine activity, and decreases uteroplacental blood flow, and that is increased in preeclampsia. And then endothelin 1, its effect is it's a potent vasoconstrictor and platelet activator, and that is also increased in preeclampsia. So there's also a plasma volume loss, hypoalbuminemia, and vasoconstriction, and these all lead to systemic hypovolemia and decreased placental perfusion with a decrease in transplacental gas exchange. Also, anti-angiogenic proteins lead to systemic endothelial damage, especially in the kidney, liver, and brain, and this combination of effects tends to lead to the seizures of eclampsia that can come after preeclampsia. So the featured article today in the current research segment comes from the June 2018 edition of Anesthesia and Analgesia. And the topic today is perioperative nutrition. And the title of my study today is American Society for Enhanced Recovery and Perioperative Quality Initiative Joint Consensus Statement on Nutrition Screening and Therapy within a Surgical Enhanced Recovery Pathway. Wow, what a mouthful. Now, because the anesthesia provider typically only is in contact with the patient for about the 24 hours or so surrounding surgery, it's easy to give this concern or chalk this off to the surgeon to say, the nutrition is something that you should, pay attention to. The surgeon sees the patient in the before surgery, after surgery, so it kind of makes sense. But I want to say, and what these authors in this consensus statement want to stress to us, is that because perioperative nutrition is so important for the long-term outcomes of this surgery, this is something that everyone involved in the patient's care should find very important and should stress. Now, what we do know is that the more providers or the more providers that stress the importance of nutrition to a patient while they're in the hospital, the more likely that patient is going to follow the recommendations of that provider. So now, what do we know on the subject of perioperative nutrition? Well, between about 1/4 and 1/2 of patients undergoing surgery are at nutrition risk, and about 2/3 of patients coming in for GI surgery are at that same risk. Malnourished surgical patients have significantly higher postoperative mortality, and that's 5 times. Now, also increased morbidity, 3 times, increased length of stay, increased readmission rates, increased hospital costs. Every dollar spent on nutrition services saves $52 for the hospital. Now, the National Surgical Quality Improvement Program, the NSQIP, says that malnutrition is among the few modifiable perioperative risk factors associated with poor surgical outcomes, including mortality in surgical patients. Numerous high-quality studies have shown that preoperative nutrition, regardless of the route of administration, in malnourished patients before GI surgery reduces postoperative morbidity by 20%. It's huge. The postoperative period is a highly catabolic period, and thus adequate nutrition is imperative. A delivery of nutrition on the first postoperative day is an independent predictor of postoperative survival at 5 years in cancer surgery patients. Now, even though it could be highly impactful, only 1 in 5 hospitals currently utilizes a formal nutrition screening process. Prior to this consensus statement, there were limited surgical and preoperative society guidelines for screening and optimizing nutritional status. Here's what this group of international experts concluded in New York in December of 2016. So, in the pre-op area, here's their recommendations. Preoperatively, now they want you to check the EMR for nutritional status. Okay, conduct perioperative nutritional screening, the PONS screen. The PONS determines the presence of nutrition risk based on the patient's body mass index, recent changes in weight, reported recent decrease in dietary intake, and the preoperative albumin level. They recommend in some patients to get a CT to evaluate lean body mass. They recommend an increased protein intake in the patients leading up to surgery. 1.2 grams per kilogram per day is at least the level. It's between 1.2 and 2. At-risk patients should be referred to nutritionists for formal consultation and started out on oral nutritional supplementation if possible, and parenteral nutrition if not possible. All patients should take immunonutrition containing arginine and fish oil. Also, the NPO at midnight should be abandoned. Okay, that's something that really, stands out in the anesthesia provider's mind. NPO at midnight, what they're recommending is that patients with minimal risk for aspiration, they should eat solids up to 8 hours before surgery, and they should continue clear liquids for up to 2 hours before surgery. Okay. So post-operative period, high protein diet on the day of surgery. So start that high protein diet, except when there's increased risk for disrupting the surgery. They recommend this. So they say that this old, slow advancement of diet, is out, and we should be pushing the high protein early on because of this high catabolic state. Now, reaching a protein goal is more important than the calorie goal. Also, immunonutrition, so containing fish oil in all patients for 7 days following surgery. Tube feeds or parenteral nutrition is recommended for patients unable to meet the 50% of their nutrition goals. So the nutritionist can determine what the calorie intake should be, and if they're not meeting that, then they should get it in one way or the other. Also, the cutoff for gastric residuals to determine feeding tolerance should be 500 milliliters. So every institution kind of has their own cutoff, but this is their recommendation. So now what can we do as anesthesia providers today, okay? So what we can do is in the pre-op area now, or actually in the pre-op clinic now, we can assess their nutritional status. We can do the PONS screen on them, and if a patient is at high risk for malnutrition, we can refer them to a nutritionist to help improve that. In the preoperative area, we can also do a screen to see if the patient's at risk as well. If they are, we're going to flag that patient, or we're going to talk to the surgeon and say, maybe this is someone that we want to get a nutrition consult on because they're at higher risk for malnutrition in the post-operative period. Also, in the post-op period, when we're on our post-op rounds seeing the patient, we can talk to them, we can talk to the nurses, we can see if they're meeting their goals, their nutrition goals at the time. If not, we can bring that to the attention of the surgeon and of the care team, and we can intervene appropriately. Now, for more information on this study and their recommendations, you can look at the June 2018 edition of Anesthesia and Analgesia. All right, today in our anesthesia news segment, a new study published in the Mayo Clinic Proceedings show that the rates of heart attack, of MI, in the peripartum period are on the rise. What this retrospective study showed was that in 49 million births, out of 49 million births, they found that 1,061 had a heart attack during labor and delivery, 922 had heart attacks during their pregnancy, and 2,390 women had heart attacks after they gave birth in the first 6 weeks after. The research found that acute MI occurred in about 8 cases per 100,000 hospitalizations for pregnant women, up to 6 weeks after childbirth. Now, this is an increase in 25% since 2002. Now, although this number is small, it's not insignificant, and so this is something that we definitely should be aware of, and look into, the reason why, behind this, why this increase is going on. So as for announcements today, so we've got a couple of conferences coming up, exciting conferences, so make sure that you sign up in time for these things. So first, the Society for Airway Management, SAM. The conference is coming up September 13th through the 16th, 2018 in Chicago. Sign up today. The American Society of Nurse Anesthetists, the AANA meeting, is September 21st to the 25th, 2018 in Boston, Massachusetts. That's going to be an exciting one. Also, the American Society of Anesthesiologists main meeting is October 13th to the 17th, 2018 in the beautiful San Francisco, California. Sign up now, sign up today. I know that one is always a great conference. A lot of wonderful topics there, speakers, and a lot to learn, a lot of networking goes on there. The American Society of Regional Anesthesia and Pain Medicine fall meeting is November 15th to the 17th, 2018 in San Antonio, Texas. And then also, the 32nd Annual Challenges for Clinicians Conference is held this November 30th to December 2nd, 2018 at the Drake Hotel in Chicago. This is a great conference that both you get hands-on and didactic courses to improve your skills as a clinician. All right, thank you guys again for joining me today for this episode of Anesthesia Circuit with John Kenny. I think we touched on some great topics today, some very important things. Please, as always, please leave me any comments, suggestions, anything that I can do to improve. I'll be sure to listen to those things and get back to you. Anything that you want to hear, topics going forward, please let me know. Leave the comments below. Also, please tell your friends, like, share, let everybody know what's going on here so we can get the word out so that more people can be informed on everything anesthesia. This is Anesthesia Circuit with John Kenny. I'm John Kenny, the only show dedicated to all things anesthesia. Information disseminated in this show are for entertainment purposes only. Please consult your professional societies for the most up-to-date information on practice guidelines. Kenny's Anesthesia Circuit is a Vigilant Medicine Media production. Copyright Vigilant Medicine Media 2018.